Yeah, so kind of we have new data through the ASCENT studies that trastuzumab is actually moving on to the first line setting in the metastatic triple negative setting, both for PDL positive and PDL negative tumors. So the way I see these findings further affirming that practice is that sacituzumab is likely going to be used in that first line metastatic triple negative setting. And after that, I think depending on patient's clinical status, they may either be referred to additional clinical trials with other ADCs, or if they don't have additional options, I think selection of potentially trastuzumab deruxtecan can be definitely offered to select patients with HER2-low disease. Yes, so kind of as expected, patients who had had more prior lines of therapy tended to have shorter progression-free survival. This matches what we see in clinical practice. In this study, the median prior lines of systemic therapy in HER2-positive patients were 3, and median lines of prior therapy were 4 in those with HER2-negative disease. So this was a more heavily pretreated population compared to some of the clinical trials that have read out on T-DXd. So I think it's important that in addition to seeing for example, we saw shorter progression-free survival relative to Destiny-03 data in patients with HER2-positive disease. And this may be a combination of more prior lines of treatment, but also that this we generally see in the real world that patients treated outside of a clinical trial tend to have different comorbidities. They're less able to tolerate the treatment, and it's not unusual for us to see less robust clinical outcomes when we use these agents outside of a clinical trial. But I think definitely when we analyzed results by lines of therapy, definitely the more prior treatments patients had, the less likely they were able to respond, which generally matches clinical oncology practice trends that we see in routine clinics. So there is a lot to be done in the space of how to optimally use trastuzumab deruxtecan. It's clearly a highly active agent, but not every patient responds and not every patient has a sustained response. So the biomarkers that are being investigated even start with having a more accurate characterization of HER2 levels. We know that HER2 is a very dynamic biomarker that the traditional immunohistochemical antibody stains may not tell the whole story in terms of just how much HER2 levels there are. This particularly applies to the HER2-low and ultra-low tumor types. So there are ongoing studies, including, for example, the Quantify-HER study, which is also being run out of the Translational Breast Cancer Consortium, where the levels of HER2 level are being quantitatively quantified, so that we can essentially use HER2 levels as a continuous variable. And the hypothesis is that patients who have higher levels of HER2 are likely the ones that are going to benefit the most from T-DXd. So kind of understanding exactly how much HER2 levels are actually present in tumor types, understanding HER2 tumor heterogeneity, where if only one part of the tumor is very much HER2 driven, but the other parts are not, I think we have increasing data that these are the tumors that are less likely to have a sustained response to T-DXd. So kind of understanding actual levels of the signal as well as heterogeneity, and then ongoing basic translational research is very much focused on understanding the acquired resistant patterns that we're seeing to this ADC. Is it starting at the target level, or is it related to the payload? So these questions are currently under active investigation.